Let's get started with our final section of the breast. So today we're going to begin by talking about the male breast, and then we're going to go into Doppler evaluation of breasts in general, and then the sonographically guided breast interventional techniques, special considerations with augmented breasts, and emerging sonographic technologies. So we'll try and get through this relatively quickly. So the male breast is going to be structurally somewhat different from a female breast in that they don't need to have glandular tissue because they're not going to be lactating. So the normal male breast is going to consist mostly of fat with some connective tissue to provide it with some structure, and then some rudimentary subareola ducts that can help drain the breast, but obviously won't be used for lactation, so they are not going to be as developed as the female breast ducts. Skin in the males is typically a little bit thicker, and most males will have much larger pectoral muscles than you would note on your female breast. So some clinical indications of male breast assessment would be enlargement of one or both breasts, nipple discharge from one or both breasts, and tenderness or palpable mass. So a common thing that is probably the most common disease process seen in males is going to be gynecomastia. So gynecomastia is considered a benign male breast enlargement, and it is caused by abnormal growth or proliferation of ductal and stromal tissues. So this is most often caused by some type of hormonal imbalance where their estrogen levels are going to be higher than expected, or maybe they're going to have some low testosterone levels. Sometimes those changes can be pharmacologically produced. Other times it's a pharmacologic response to a pharmacologic exposure that would cause this to happen. And then finally, it could be because of a pathologic condition, such as maybe an adenoma of the adrenals or something like that that would adjust those sex hormones and change that, affecting the secondary sex characteristics of the male. Now, if it's a hormonal in nature, it's usually going to affect bilateral, and it will persist until the hormonal changes are resolved. If it is more unilateral, then it's usually not systemic. It would be more likely to be a mass or something causing just the effect of one breast. Oftentimes males will feel mildly tender area of fullness or some nodularity or lumpiness centered under the areola, and typically these are going to over time get a little bit larger in size to where they can be greater than 2 centimeters. If they're completing a mammogram of a gentleman with gynecomastia, they'll often see it appear as a fan-shaped subareolar density, so just below the nipple. And then as it progresses over time, it takes on more of a dendritic form. And dendritic in this case is referring to, if you can go back to your anatomy and physiology and think about the dendrites of the neural system, it's going to look somewhat like one of those dendrites with that spiculated extension of the mass. If we look at this then and follow it up sonographically after the mammo, we'll typically see a hypoechoic nodular area, which can have some of those striations or that dendritic appearance, again, beneath the areola. Now, if it's earlier in the process, those dendritic appearance may not have been produced yet, and you might see it look somewhat more just lobulated. This area will typically have increased vascularity, and like I said, over time may then eventually produce those dendritic finger-like extensions. So here's an example where we're looking at it on mammogram. You can see that it's a radio-opaque area. And then as you correlate that with the ultrasound, you see the ultrasound here has that dendritic type appearance. So this is a more mature appearance. Now, we typically think of breast cancer as being limited to females, but it can affect a male. Things that are going to put a gentleman at higher risk for breast cancer is going to be their age. So as they grow older, just like with the female, they're going to be at higher risk of having breast cancer. There's also a genetic link. And then similarly to females, having those elevated levels of estrogen are also going to be linked to a higher risk. So people that have been on exogenous estrogen therapy, maybe first transitioning, or somebody that has some sort of disruption in the secondary sex hormones, like coming from the adrenals, causing elevated estrogen and maybe a decreased testosterone from the reticularis of the adrenal system. All of those can have a link to the risk of male breast cancer. When they do identify a male breast cancer, it's usually beneath the areola, and it's going to follow those same characteristics that the female breast cancer followed. So it's going to be hard, fixed, painless, may cause bloody discharge, will often cause retraction of the architecture of the breast, can result in ulceration of the skin, and then palpable axillary nodes. So palpable axillary nodes, excuse me. So very much similar to the female breast cancer. We talked about how gynecomastia appeared, but when we look at how a male breast cancer would appear, it's again going to appear very similar to a female breast cancer. So radiodense lesion on mammo, and then when we look at it, it's going to be a solid, most likely posterior shadowing, complex. It's going to be highly vascular and have all those same qualities we're used to on the female breast cancer. Quick question for understanding to read through that. Okay, now we're going to move to the Doppler evaluation of the breast. So Doppler can be utilized in male and female breasts, and it's going to be very essential in our diagnosis. It's one of the best benefits of sonography. So uses of Doppler in breast sonography is to document vascular pattern and identify complex, solid, or cystic masses, and it also helps us identify lymph nodes. It allows us to demonstrate fibrovascular stock within intraductal or intracystic masses when we have those papillary growths. And it allows us to identify exactly the origin of the papillary growth by identifying that vascular stock. It allows us to differentiate between hypoechoic solid masses from cystic masses, in that our cystic masses will have no internal vascularity, whereas our hypoechoic solid masses will. It allows us to look at, differentiate hyperemic inflamed tissue from normal tissue. So we know with the inflammation process, we need to increase our vascularity to the area. So Doppler can help us identify those particular areas. It allows us to differentiate a tumor from a scar, in that a tumor will most likely have vascularity, where a scar is going to be fibrous tissue, so it won't demonstrate that vascularity. It also helps us to differentiate between vessels and ducts, confirm clot, and identify the occlusion level of a clot. It also allows us to induce movement of lightweight particles in cystic structures. So the change in the Doppler frequency when we're using our colored Doppler can cause any free-floating debris in a cyst to float, kind of like a snow globe, and that could help us evaluate whether that debris was truly debris or whether it was some sort of mass attached to the cyst. So it can help with that movement of lightweight particles. And then finally, it allows tissue response during the performance of vocal fremitus. Vocal fremitus would be making, having your patient make a humming type sound, like as you scanned. And that humming sound coming from the chest would cause the tissues to vibrate if they're normal tissues. If you had a solid adhered mass that was most likely going to be cancerous, then that particular tissue wouldn't vibrate. And we have an example here. So here's an example of a patient, just a regular B-mode imaging on the left, looking at that breast mass. Obviously, it's shadowing, but perhaps the tech is wondering if it's scar tissue or something else. So they had their patient make the vocal fremitus noise and put color on at the time, and all of the mobile tissues are going to move, creating that Doppler response, whereas that adhered solid mass is going to stay very still, creating this ability to identify the solidity and the adherence of that mass. Okay, so as most of you have experienced in clinical, sonography can also be used to guide diagnostic and therapeutic procedures, one of those being cyst aspiration, another being drainage of a fluid collection, or even perhaps an injection of an antibiotic or something if there was an abscess. It can be useful in lymph node sampling, biopsies of masses, insertion of pre-surgical dye or a guide wire to help surgeons identify the mass visualized on an image when they get into the surgical suite and dye or the wire localization would lead them right to the mass. It also assists in metallic clip placements. So whenever you're doing an interventional technique or procedure, you're going to want to make sure that you as a sonographer are going to be responsible for the patient preparation. So first thing before you do anything with the patient is you want to make sure that you receive their consent. And in order to receive full informed consent, you have to present the procedure to the patient with all the details so they're able to make an educated decision whether they want to proceed or not. So that would involve the processes of the procedure, details of how it's going to go, an explanation of the risks and the benefits, and then allow them to make that decision and sign the consent for you. Once the consent is signed, you're going to want to prepare the patient. So that would mean having them change their clothes, get in the appropriate position where the mass was best seen. And then you need to make sure that you are preparing to assist the doctor by setting up those sterile trays, gathering all supplies, making sure that everything is prepared in that way. And then, of course, once you have the physician in ready to complete the procedure, then you want to make sure that you complete timeout and side out practices. So you take a timeout, you verify the side, you identify where the mass should be, and identify where the site can be. And typically they'll do a mark where they're going to complete the procedure. So guidance is going to vary depending on the physician that you're assisting. Most radiologists will really prefer to freehand these, meaning that they're not going to use a biopsy guide. We looked at those biopsy guides in class where it was that plastic clip on your transducer, and they would simply advance the needle down the clip. Most radiologists will not use those, and they will simply freehand or scan while they insert the needle, watching the needle as they go. The biopsy needle can either be inserted across the transverse face of the transducer or in long with the transducer, and the appearance of the two different approaches is going to be very different. The essential thing is that you're always monitoring. If you're the one scanning, you're always going to be monitoring the tip of that needle to ensure that you know the depth that tip is out. If you get off axis of the tip, there's a possibility that they could advance it too far within the breast, take a biopsy from the incorrect place, or even go so far as to cause a pneumothorax by nicking the lung. So here's a couple examples. So this would obviously be a long evaluation of the breast. Here they've turned the transducer to transverse, and this would be a transverse approach where he's just watching for the tip of the needle, which we see here in this echogenic area as it enters into the mass. We have a long approach where he's advancing the needle down the length of the scan line so that the physician is able to watch the needle all the way as it progresses toward and then enters the mass. Another approach they can use is scan long and enter across 90 degrees to the scan line or at a different angle. But again, it's going to be really important to watch that tip, because if you don't, if you're watching some other area of the needle or off axis of the tip, then they can totally miss the mark, as you see here in B. So one of the common biopsy approaches is going to be the fine needle aspiration, which you guys are used to seeing or hearing about with the thyroid. These are going to be very similar to how it's produced in the thyroid. However, you might need a longer needle. So you're going to use the small 22 to 25 gauge needle and attach that to a syringe with pressure or vacuation of that syringe to create a pressure vacuum in it, so that as the physician jiggles those small needles around in the tissue, it is going to have that suction to try and pull some of those out to sample. So with the fine needle aspiration, this is the fastest, the cheapest, and the least traumatic because of the size of the needle. It usually extracts just cellular material from a mass or lymph node. But it takes very small samples. So lots of times these can be non-diagnostic because of the limitation of the sample size. If they need a larger sample size, then they can go with the large core biopsy or the vacuum assisted biopsy. So a large core needle biopsy would be something like it's almost like a gun, like the long fire starters for your fireplace, where you pull the trigger and it starts the fire. These looks very similar to that. So with these large core needle biopsies, they would insert the needle end of that gun into the mass, or to the margin of the mass, and then when they liked their placement, they would fire that biopsy gun, and it would send out a large bore and take a bore of tissue sample, pull it back, and then they would test that tissue sample. So the bores of these are usually about 14 to 18 gauge and about 2 centimeters in length. Now, a little bit more complicated and able to get a larger sample yet is going to be the vacuum assisted biopsy, or mammotomy. This is going to use an 8 to 11 gauge needle, and this is used for sampling very small suspicious lesions where a fine needle or a large core biopsy might either miss the mass or not get enough cells to adequately test it. So in this case, that vacuum assisted needle is going to be advanced directly under the mass. The needle aperture is then opened, and then suction is applied to and rotated to kind of cut and suck the specimen into the bore. Okay, here you see that biopsy gun. They're coming right to the margin, and then they are shooting the needle in, taking that large bore biopsy. It's going to pull it back, and then they'll have a nice core biopsy of that mass. Here you're seeing the vacuum assisted, so they're inserting the needle to the inferior aspect, and then they're vacuuming and cutting that area off of the mass, and you're going to see a ring down artifact from the air in the system. We can also have a role in brachytherapy, so it's called breast conservation therapy, and this, or BCT, and this is an option for localized cancer where they utilize a lumpectomy and radiation treatment. Then we have brachytherapy, which is the implantation of a radiation source into the breast near the lumpectomy after the treatment. So they would remove the cancerous mass and then insert a radioactive material that would emit radiation to hopefully kill any cancerous cells that may be retained in the margins of where the lumpectomy was completed. And so we could assist in the placement of that radiation source into the breast. We can also guide a lumpectomy or a seroma site. We can use guided placement for a catheter, use guided percutaneous balloon devices that might be utilized to help stretch breast tissue in preparation of a reconstructive breast procedure post-op mastectomy. Now, the augmented breast is going to include a whole number of considerations. So we have to first understand where the augmentation is placed. So augmentation is typically saline or silicone. It's usually placed either between the retromammary layer and the pectoralis muscle or underneath the pectoralis muscle. When we have a normal saline augmentation or implant, we can usually see it as a single anechoic lumen, and then it will have a little, almost a little knob, which is the filling port where they can add or take out saline. That little port is going to appear as a lump near the areola. So be aware that you're going to find that when you're looking at the smooth capsule of the implant, you are going to see that irregularity at the filling port. Silicone will have single or often a double lumen, and so you can see that appear as a capsule shell echo on your image. And usually around both of these augmentations, you'll see a fibrous capsule develop of breast tissue, and the texturing of the implant shell kind of causes that capsule to be developed and then to not contract, misshaping the capsule. So some of the common findings you'll see with the augmented breast is that there can be some linear infolding of the implant shell, causing this radial fold to kind of like rays of the sunshine kind of come out from that areola area, and it can result in some lobulation or contouring, wrinkling of the outline of the augmentation. So we'll also see some reverberation and sound propagation artifacts within this, just like any other large fluid-filled container like the bladder. That's going to be a common artifact to affect an augmentation. There can certainly be implant complications where the implant can change shape, contour, size. It can even have some contracture. It can herniate either through tissue layers of the patient, or it can herniate in the wall itself. It can rupture and deflate. So one of the common things we are going to be looking at is evaluation of the implant integrity. Saline typically ruptures more easily, but fortunately it is not as dangerous to the patient as if we have a silicone rupture, which can make the patient kind of ill. Silicone rupture would cause silicone to migrate outside of the implant through the breach in the shell, and then the body would typically create an encapsulation around the ruptured area to hopefully maintain that silicone in a confined area within that capsule that was produced from the fibrotic changes when the implant was inserted. However, sometimes this process can cause a step ladder or a parallel line type sign that would be indicative of a rupture. Here you see an extracapsullary rupture, and you're seeing that ladder type sign. On the right, you're seeing an inflammatory response to a rupture, creating a snowstorm type appearance. There's also autogenous breast reconstruction, where a patient's own tissues are utilized to reconstruct a breast following a mastectomy. So oftentimes with this, what they'll do is once the mastectomy is complete and healed, they'll actually insert some balloons underneath the skin and gradually, over months of time, gradually pump those balloons up, causing the skin to stretch and make room for reconstructive surgery. One of the complications is this is just because of all of the trauma to the area, it can be difficult to maintain vascular integrity. And so these patients are always going to be at risk for a vascular compromise, which would lead to skin and tissue death and necrosis. A couple different approaches that they might use for these autogenous, meaning from itself, breast reconstruction would be the tram flap procedure, where they use the transverse rectus abdominis myocutaneous approach, and they utilize muscles from that general area to reproduce the breast. They can also do a latissimus dorsi myocutaneous flap, where they're utilizing those muscles for the recreation, and then the autologous fat transfer, where they're taking adipose tissue from other areas of the body and then transferring it to the breast. All right, that brings us to technological advancements of breast imaging. Most of these you're going to be pretty familiar with, so we're going to go relatively quickly, but you know that 3D ultrasound is an approach that can be useful in most sonographic imaging, so it's no different within the breast. They can also use real-time correlation with MRIs and CTs, where you can take a patient's, let's say, MRI of their breast, upload it to an ultrasound system that has certain capabilities, and then you can merge that MRI with your ultrasound as you scan. So you're having the soft tissue detail from the MRI, and yet you're adding things like attenuation properties and vascularity from the ultrasound. There's also automated breast ultrasound systems where the breast is placed in basically a bath of water and an automated approach. So you wouldn't technically be doing the scan at all. It would be automated and create an ultrasound view of the entire breast. And then we have elastography, which we're familiar with from the liver. We know that we can use elastography to evaluate the stiffness of tissue, and we know that the malignant tissue tends to be more stiff. So we can use elastography related to how much deformation, how much change in the mass occurs, called the strain, when we apply pressure. And that pressure we apply is called the stress. So we apply the stress and we assess the strain. We can do this a couple different ways. We can do this with pressure from our hand, or we can do this with shear wave elastography, where it's a change in the pulse by the ultrasound. So it's controlled within your ultrasound system rather than by our hand pressure, and it looks for those changes in compressibility of the tissue and then applies a color map, demonstrating softer tissue in comparison to harder tissue, as we're going to see here in a minute. Most benign masses are going to appear soft. Most stiff or malignant masses are going to appear. So here you see an example where we have a very stiff mass here in the blue, with all the other surrounding tissue being very compressible. So that would be a concerning sign. Here we have just a cyst. You see how the whole thing compresses similarly to the rest of the breast, which would be a good sign of it being benign. Here's a couple more examples where you're seeing this has very similar compression to the surrounding tissue, whereas this one is very much more stiff on the right. So that would be a concerning sign for that patient. Automated breast ultrasound is one of those I just mentioned. This works really well for women with high breast density that needs a whole breast scan. And it can supplement whole breast screening exams, and they're automated systems. So it's less user dependent. It also evaluates the whole breast rather than a quadrant. MRI also works well for ultrasound assessment, for breast assessment, because of its very high soft tissue resolution. And that should pretty much wrap this up for breast. So good luck on your exam.